Hello, everyone. This is Michael Masamba, CEO and founder of Masamba's Affordable Housing and Counseling. And in this video, I'm going to address a question I had regarding what are some of the best therapeutic techniques or some of the best therapeutic modalities to use when helping individuals that are suffering from chronic mental illnesses. So I wanted to go ahead and tackle this question and to answer the question in its entirety. Now, this is a very complex question because there's a lot of therapeutic modalities that are used in the field of social work, particularly in counseling. And of all the modalities that are used, I tend to believe that there's a fair amount that can be integrated into one's practice to best inform uh, client to therapist interactions and to best help individuals cope with some of those mental health symptoms. So I'm going to start off by sort of summarizing what I believe the best therapeutic modalities are based on my experience helping individuals that are suffering with severe mental illnesses, both outpatient and inpatient. These modalities seem to have really worked and really helped me when dealing with these particular clients. So let's go ahead and start with solution-focused therapy. Using a solution-focused approach, I think seems to be very, very helpful. So solution-focused therapy is a therapeutic modality that states that client problems occur in the context of human interactions, and that such issues are compounded by the client's lack of social skills or the client's poor social skills. So this therapeutic modality really, believes that if you can fix how an individual interacts with his or her social environment, that can lead to a reduction of mental health symptoms in that particular client. So some of the core techniques of solution-focused therapy are things such as scaling, which involves asking the client to rate on a scale of 1 to 10 the severity of their symptoms and to sort of describe their goals using this scaling technique. And also using what's known as the miracle question. This is a question that asks the client, if you went to bed and woke up sometime in the morning and this particular problem that you have is gone, how would you know that the problem is completely gone? And this question attempts to see what the client is hoping to gain out of the therapeutic alliance. And so you've got the scaling, you've got the miracle question, and then you also have a technique known as reframing problems in a positive way in order to try and help the client change their perspective on the problem and to see that there is a positive side of whatever they're going through. So these are some of the techniques of solution-focused therapy. Again, this modality is strictly dependent on the idea that these symptoms or mental health issues occur because individuals struggle with social skills and need help with figuring out more effective ways to interact with their peers and their social interaction. So the solution-focused approach, I would say, is very helpful and very beneficial when dealing with individuals who have chronic mental health issues particularly inpatient, and when trying to help these individuals better cope with their environment and to be stable in their social environment, and while helping them to fix the way they interact with their peers in order to ensure that these individuals have a secure placement and a secure shelter for themselves in the long run. So the second modality I wanted to address that's very useful in terms of integrating in one's practice would be dialectical behavior therapy. And this particular modality is actually used in multiple settings, whether we're talking about a long-term care facility, um, a still a residence, or even outpatient facilities use this dialectical philosophy, this dialectical approach. And this is typically used when you're dealing with individuals that have borderline personality disorder, or clients that are suffering from a severe type of bipolar disorder. Um, you even see this modality used when you're dealing with individuals suffering from a combination of schizophrenia or schizoaffective disorder combined with bipolar disorder. These clients tend to be very difficult to tame and very difficult to deal with. So the dialectical philosophy is comprised of individual therapy, typically about a couple of sessions per week. You have group counseling that's included in that. Again, a few times a week, a couple of hours, and then you have what's known as telephone coaching, 24/7, which enables the client, typically, as I said, that the individual would have borderline personality disorder, to have access to 24/7 care whenever they're undergoing severe episodes of their disorder. And typically, these severe episodes would include or comprise of suicide ideations or potentially homicide ideations. Those would be the more severe presentations of either bipolar disorder or um, borderline personality disorder. And so the goal of this dialectical philosophy is to try and restabilize the client's mood by exposing them to as much clinical interactions as possible throughout the week. I should mention that there is a therapist consultation piece to this because it's very common to see therapists experience what's known as uh, clinical burnout from helping individuals that have severe cases of borderline personality disorder and schizoaffective combined with severe manic bipolar disorder. So that is the case with dialectical behavior therapy. It's perhaps one of my favorite therapeutic modalities, just because the 24/7 telephonic coaching piece is included there, and that's very useful when you're dealing with clients, especially inpatient clients. So the next modality that I would like to include in this list is schema therapy. And schema therapy is oftentimes confused with cognitive behavior therapy or even other forms of uh, cognitive therapy. It's a little different, I will say. So schema therapy actually looks at challenging what's known as early maladaptive schemas about the client and other people in the client's environment. And oftentimes, these maladaptive schemas create or form due to a failure to meet early childhood core needs. Typically, these needs are not met because of faulty parenting. Although this therapeutic modality has gotten a lot of criticisms in the past for blaming parenting or the parents for the client's symptoms. And so mental health symptoms don't always occur because of faulty parenting, but typically there is an underlying childhood reason for the development of these symptoms. And schema therapy really looks at the core central beliefs that the client has and really ties those beliefs with faulty childhood. And because most of these schemas would have developed over time, um, the central piece or the central goal of this therapeutic modality is to challenge irrational schemes and to help the client realize that some of their thinking patterns are not always accurate and that there are ways to um, restore what's known as rational thinking in the mind of the client. So typically, schema therapy works more effective when you're dealing with higher functioning clients. When you're dealing with individuals that have severe mental illnesses such as schizophrenia, um, and schizoaffective or schizophreniform disorder, what you often see is that there is a lower IQ in these particular clients, and there are some delusions that are very difficult to to change. And there's a derailment of speech. There is speech incoherence. Typically, when you're dealing with clients that have more severe mental illnesses, schema therapy isn't as effective. It's more effective when you're dealing with higher functioning individuals who can recognize that their thinking patterns may be irrational, and individuals that can be reasoned with um, in a logical sense. So moving on, I will say that another therapeutic modality that I have integrated into practice is what's known as reality therapy. And this therapeutic modality states that problems occur when people try to meet their needs for power in a negative way. And this typically results in disconnected relationships. So the root of reality therapy is really looking at relationships as the main problem for mental health symptoms, and this need for power, and that everyone has a certain need for power, and how you try to obtain that power typically is what causes what's known as a fragmentation of relationships or fragmentation of one's mind and one's social uh, environment. And so the William Glasser, the individual that created this therapeutic modality, actually had different components of this theory. He has what he calls the 7 caring habits and the 7 deadly habits. And those 7 caring habits are what's known as supporting, encouraging, listening, accepting, trusting, respecting, and negotiating differences. So those are the 7 caring habits. And according to Glasser, the 7 deadly habits are criticizing, blaming, complaining, nagging, threatening, punishing, and bribing or rewarding to obtain control. And so this theory really suggests that the more an individual can adhere to the 7 caring habits, the more likely they are to refrain or to uh, uh, exclude themselves from the presentation of mental health symptoms. Whereas the more an individual engages in the seven deadly habits, which are criticizing, blaming, and complaining, and so forth, the more likely an individual will suffer or experience mental health symptoms. Um, Again, it's a very good therapeutic modality in the fact that it helps clients, um, especially clients that have chronic illnesses, realize that oftentimes human beings do engage in what's known as self-defeating behaviors, which would be the seven deadly habits, and that there are ways to change one's behavior in a positive way in order to control or to mitigate the presentation of mental health symptoms. Again, and one of the central pieces to reality therapy is this idea that relationships are vital, and that the more healthy relationships an individual has, the less likely they will feel fragmented, and the less likely they will feel that they are suffering or having a presentation of symptoms. So moving on, the next modality that I want to add to this list is motivational interviewing. Now, motivational interviewing is very unique and somewhat different from these other modalities that I have listed, in a sense that it is very brief and somewhat short. Oftentimes, you'll see motivational interviewing combined as a central piece into other therapeutic modalities. You do see this modality used particularly in treating substance use disorder, along with other mental health illnesses that require a sense of motivation and a sense of action from the client. So what is motivational interviewing? So motivational interviewing is a modality that tries to expand the gap between the client's choices and the client's goals. And essentially, the ultimate purpose of this modality is to illuminate, I should say, how a client's unhealthy choices do not line up with those goals. So on one hand, you have the goals, and then on the other hand, you have the choices which contradict those particular goals, and the choices which clearly make those goals impossible to achieve. So the role of the therapist would be to reveal to the client how those goals are in clear contradiction with the choices. And so revealing the discrepancy is the ultimate purpose of motivational interviewing. Now, this modality is pretty complex when you look at it in its entirety. There are different stages of change when a client is finally getting ready to abandon whatever detrimental behavior they have that is preventing them from achieving their goals. So the stages of change are stage one, you've got the pre-contemplation phase. This is where there's no serious thoughts about any change in the behavior, and the individual is typically unable to acknowledge the impact on their mental health that this particular behavior is having. The stage two, you have contemplation. This is where the individual is starting to have thoughts about how this maladaptive behavior could be impacting them. Stage three, you have the preparation phase. This is where the individual has made some sort of a commitment to change. Now, doesn't necessarily mean that they're willing to act upon that commitment, but they have had thoughts about changing this behavior. And then stage four, this is the action phase, also known as the willingness phase. And here you start to see early signs of self-efficacy, and you have the willingness to adapt an approach that will lead to change. And then the fifth stage is what's known as the maintenance stage. This is where the individual is engaging in deep reflections, and they're willing to maintain, and to prevent themselves from going back into a state of regression, where they would fall back and essentially start engaging in that detrimental behavior again. So those are the stages of motivational interviewing. Um, the goal is, again, to help the client move forward, and to help the client develop a sense of positive change. So, moving forward, another theory that is helpful when you're dealing with clients is rational emotive behavior therapy. Now, very similar to schema therapy, as I had previously mentioned, rational emotive behavior therapy is a modality that actually states, or this is what the modality states, that circumstances do not cause symptoms, but that rather the client's perception of the circumstance is what causes the symptoms. So essentially, it's all a matter of perception, and that if we can fix our perception, or the client can fix their perception rather, that ultimately this could result in rational thinking, and this would result in a reduction of mental health symptoms. So this modality, again, is very contradictive. Now, there are some techniques to rational emotive behavior therapy. For example, there's what's known as the ABC model. This is Again, this is a theory, that so the ABC model essentially looks at, first you have the A, so this is where the attention is paid to an event, also known as an activating event. So the event would cause the client to experience some sort of stimuli that would cause a reaction from the client. And then you've got the belief. This is how the client interprets that particular stimuli. And then C, you've got the consequence. This is the feelings of the event. And so rational emotive behavior therapy believes that if we can create a positive ABC model, that ultimately this could lead to the reduction of symptoms. Now, there are some controversies underlying this theory. And the first controversy, or the criticism, I should say, is that sometimes situations can be so horrendous that the client's perception isn't always at fault. So it's not always a matter of having a faulty perception. There are cases where a situation truly is bad enough to cause mental illnesses. So that is to say that an individual's perception isn't always distorted. Sometimes you can have an accurate perception to a bad situation. That's one of the criticisms of rational emotive behavior therapy. Again, it's one of those modalities that you want to use when you understand that the client does have a history of irrational thinking, and when you feel comfortable and confident that the client's level of functioning is high enough to help them engage in what's known as rational thinking. So typically, this mainly works with higher functioning clients who have a high level of IQ. Typically, if the individual's IQ is 90 or above, you can always challenge some of those faulty perceptions that they may have, and help them to realize that there are some gaps in their thinking, and that rational thinking can be promoted in a sense. The next modality I want to add to this list is narrative therapy. Narrative therapy is a lot different from some of the other modalities I have talked about, in that this particular theory states that there are several stories in a client's life, and that we can change a problem-saturated story into a more productive story. So it's this idea that everyone is living under what's known as a narrative, and that narrative can be either positive or negative, and that individuals' identities are formed by whatever narrative they're living under. And oftentimes, clients with presentations of symptoms have been living this negative narrative, that they're unwanted or that they're unloved and such forth, and that there is a way to positively change those narratives to help the client adopt a new perspective in life. Again, this theory is highly dependent on what's known as deconstruction, and this is deconstructing a negative narrative. Other techniques that are typically used are what's known as externalization, right? Using open-ended questions. There's also what's known as mapping the effects, and ultimately, the last technique is what's known as reauthorizing. So creating a new narrative that is more positive, and helping the client to experience a new sense of identity through this positive narrative. So moving on, I will add Adlerian therapy to this list. Adlerian therapy is a therapeutic modality that perceives or states that the clients are striving to be successful. That everyone, ultimately in life, everyone is trying to be successful, but that there is what's known as an inferiority and a superiority complex, and that clients who have the inferiority complex are can demonstrate some severe symptoms, and that inferiority isn't always a bad thing. That inferiority can be used to be motivational as well. And the author of this theory had an obsession about birth order in particular. And this was this idea that if you were the second or the third child, that you were subject to certain traits, certain characteristics, and that these could potentially impact your personality and could impact the level of motivation you had throughout life. Adlerian therapy specifically looks at challenging what's known as self-defeating behaviors, and it looked at superiority as an issue as well. Superiority to an extreme can pose issues in clients' lives, and so it's about finding a balance between superiority and inferiority. So this is one of those theories that's somewhat controversial. Some of the techniques used in Adlerian therapy are role playing. Um, there's the push button technique. There is what's known as catching oneself. That's another technique that is used in this modality. And then there's what's known as paradoxical intention. And then you also have the use of homework. So moving on, I'm going to add two final modalities to my list. And if I do exclude some therapeutic modalities, that just means that I typically haven't used them, or I haven't found them to be useful in practice. So the last two that I'm going to add, so I'm going to start with the first one here. It's cognitive therapy, the Beckian version. So CBT, the Beckian version of that, which looks at or states that clients can change their thoughts and behaviors to change feelings, and that negative core beliefs can lead to symptoms, as do distorted intermediate beliefs. And so, cognitive therapy, the Beckian version of it, really strives to challenge what's known as core beliefs and intermediate beliefs and intermediate thoughts. So, this idea that distorted core beliefs are the underlying root to mental health symptoms. Now, again, kind of like I talked about with chemotherapy and with rational emotive behavior therapy, it could be that mental health symptoms cause um, dysfunctional thinking patterns. It could be that the existence of mental health illnesses is actually what's causing irrational thinking pattern, as opposed to the opposite, as opposed to irrational thinking patterns causing mental illnesses, um, or vice versa. Again, the Beckian version of cognitive therapy assumes that the the client's thinking is what causes the mental illness, and the causality could be reversed. That's one of the criticisms to this theory, and it almost comes across as if we are minimizing the issue at hand, right? Um, Oftentimes, there are situations in life that are so severe that they can cause significant levels of pain, warranting a reason why an individual should feel the way they feel. Cognitive therapy, again, looks at perception, it looks at faulty thinking patterns. And so, this is another one of those modalities that more oftentimes works with higher functioning individuals, right? Individuals that have an average to a higher level of IQ. When you're dealing with clients with severe illnesses such as schizophrenia, um, typically this modality will not be effective because you're dealing with individuals with hallucinations and delusions. Um, and again, this just doesn't work when you have clients that have a severe level of paranoia and delusions. So there are some limitations to cognitive behavior therapy, but there's a lot of research to support its effectiveness when you're dealing with individuals that have a high IQ or a higher level of functioning. So the last modality I will talk about or add to this list to answer the question is Gestalt therapy. And this modality states that clients develop symptoms because they're not aware of their senses and emotions, right? This modality really focuses on awareness as the issue, and that we need to be aware as individuals. And then there's what's known as the 5 layers of neurosis, and that ultimately the client needs to work on removing these layers of neurosis. I will kind of go over what these layers are. And so you do have different layers. You've got what's known as the cliche layer, also known as the phony layer. This is where the individual is not themselves; they're pretending to be someone else. You have the role layer. This is also known as the phobic level, the phobic layer. This is where the individual fears of being seen for who they truly are, and so they are phobic in a sense. They fear other people will discover them for who they truly are. You have the impasse level. This is where the individual is stuck in what's known as dependency um, and so the individual seeks other people to make decisions for them. And then you have the implosive layer. This is where you've got what's known as these different defenses, um, and typically the individual is starting to make contact with their true self, but there's a lot of defensive mechanisms at hand at the impasse level, and then at the implosive level rather. And then you've got finally you have what's known as the explosive level. This is where this is the final stage, where the individual lets go of the phony roles and these pretenses I had discussed, and the individual's finally able to release a tremendous amount of energy that they've been holding in by pretending to be what they are not. So again, it's very controversial as to whether or not this modality actually works. I think that the fundamental framework and the different pieces to this modality are somewhat useful in therapy. Um, it can be said that Gestalt therapy is pro extrovertedness in a sense. It tends to promote again this explosive level, this idea that being extroverted is the route to not having symptoms, or being yourself by being extroverted. Whereas it is possible to have introverted qualities that perhaps Gestalt therapy would perceive as being phonic. And so, again, this is another one of those modalities that's somewhat controversial. Nonetheless, it does have some useful components in the therapeutic arena. So some of the modalities I didn't list, again, that's just because I haven't used them in practice. I have not integrated them in practice. Are person-centered therapy, also known as Rogerian therapy. And this is a modality that states that unconditional other regard is the ultimate root of addressing symptoms. And so, person-centered therapy really looked at the qualities of the therapist, such as empathizing, being genuine and authentic throughout therapy, as being enough in themselves to promote the mitigation of symptoms. Again, the reason this wasn't included in this list is because I feel as though therapy is more complex than just being genuine and authentic when you're helping clients. And that there are a set of techniques that typically work inpatient and outpatient when dealing with individuals with mental illnesses. And unfortunately, person-centered therapy did not make my list because I have not seen its effectiveness in my personal practice. But that's not to say that it's not an effective therapeutic modality. And so that is that. I will say that the underlying, or sort of the starting point to integrate and use the therapeutic modalities I talked about is using a technique known as meeting the client where they are. And this technique really involves being aware of what's going through the client's mind when certain problems occur, and seeking to understand what is the underlying, what's going on in the client's subconscious mind. So I'll give you an example. Let's say that client A is delusional that an ex-friend of hers has harmed / eliminated her entire family for whatever reason. And she's going on about, feeling that her family has been harmed. And this particular individual is hypermanic. Let's say that she's screaming. Let's say that she's yelling. She's hitting staff. She's hitting her people that are helping her, and that she's, no one's able to really tame her because of her erratic and irrational and manic behaviors. And so, really, when we talk about meeting the client where they're at, it's a matter of understanding what the underlying cause of those symptoms are. So, in this case, the example that I gave, the client has this subconscious need to know that her family is safe, right? And so you could start there by understanding that she does have this need, and that you can meet this need. You can help her meet this need by simply having her talk to a family member, let's say on the telephone, as evidence that they are unharmed. And the minute that you do that, you actually see that all of a sudden her brain has a sense of evidence that her family is safe, and the client realizes that her behaviors were, in a sense, irrational. Again, this example that I gave, this is more than likely an individual that has a chronic mental illness. But this is an example of how you can use evidence in practice, and how you can meet the client where they're at. So that's all I have for this video. Again, there are a plethora, I shouldn't say plethora, there's a lot of therapeutic modalities that one can use in practice. But these are the ones that I have used so far. These are the ones that I believe are deemed effective. And to answer the question that I had from this particular individual who asked this question on the website, these are the ones that I have used that seem to work the most. Again, I kind of broke them down and kind of explained them based on um, uh, level of functioning. You wouldn't use certain therapeutic modalities for clients who are higher functioning, and you wouldn't use certain ones for individuals who have a lower level of functioning. Um, I will end with this. I know when I talked about dialectical behavior therapy, I was somewhat brief, but of all the modalities that I listed, I would say one of my favorite, probably perhaps, I can pick two favorites. They're all very useful. I would say that cognitive behavior therapy, the Beckian version, has a lot of empirical research to support its effectiveness, and that the Beckian therapy would be one of my favorite modalities. The other one would be dialectical behavior therapy. And the primary reason I would say that I would pick DBT, or dialectical behavior therapy, as one of my favorite is because it has different components to it, which I didn't touch upon, which I can briefly go over. It's got this mindfulness component, right? There's actually different components of DBT. So you've got mindfulness, you've got emotional regulation, you've got distress tolerance, and then you have interpersonal effectiveness. So these are the different techniques used in DBT, and when you're able to help individuals become mindful of their social environment and mindful of themselves, you actually see that they gain a certain level of awareness. Um, and the emotional regulation piece, again, you're trying to help individuals, especially with borderline personality disorder, better regulate their emotions so that they're not ultimately engaging in self-destructive behaviors. And then distress tolerance, you're trying to reduce the level of mental pain that the client is feeling. And then interpersonal effectiveness, again, trying to heal those broken relationships that can be caused by borderline personality disorder. Again, this is evidence-based. DBT actually, when you look at the empirical research, um, there isn't a significant amount of evidence to suggest that DBT is more successful than other therapeutic modalities. DBT has been deemed to be as effective as other modalities, as some of the other modalities that I listed. Of all the modalities that I have listed, probably the most effective one, based on empirical studies and research, would be cognitive behavior therapy, the Beckian version, that is. And so that is all I have. I hope that you enjoy this video. Thanks for watching. So I'll see you guys next time.